about the doctors. How many of them are refusing posting to certain parts of the country? And of concern is the fact that if you go to the Upper West region, okay, of the 20, if you go to say the Upper West region, of the 32 doctors who were posted there, none of them is reported.
Zero.
Upper East 35, 0 reported. Northeast 19, 0. OT 21, 1 has reported. Western North 31, 2 have reported. If you go to the Western region, 37, 14 have reported. So of the 463 doctors, only 158 have reported. In effect, 34% have reported, while 66% have not reported. This morning, we've been joined by the president of the Ghana Medical Association, Professor Ernest York. We want to understand, what's the challenge? Why are these doctors refusing posting to certain parts of the country? Prof, York, good morning, and thank you very much for joining us.
Good morning, Winston, and good morning to your cherished listeners.
So we've always talked about the fact that we need, doctors. We need to have more doctors in this country. Now we've posted over 460 doctors, and just 34% of them so far have reported. The Minister of Health and Happy is giving a 1-week ultimatum. What's the challenge? Why are these doctors not accepting postings to certain parts of the country, Professor York?
Good morning once again. I mean, the issue is not a new one. I mean, I can recall 8 decades ago, that was a trend. So it's not a new phenomenon. I remember 15 years ago when I was a younger doctor, and I remember this vividly because my son is 15 years, and we attended an annual general conference in Tamale, where the theme of the conference was how to ensure equitable and fair distribution of medical professionals, including the other health workers, particularly to cater for the deprived areas. And at the time, I remember it was a minister who was for the Northern Extraction, the chief director was from Northern Extraction, and a few other high-ranking officials of the ministry. And it was our hope that, because they had some attachment to these deprived areas, that agenda will be pushed. And unfortunately, 15 years down the line, we are here speaking about it again. Now, the reasons, Winston, are not far-fetched. You and I will know. If you look at the data that was published by Ghana Health Service, it was clusters around Greater Accra. So it was Eastern and Central. These places share border with Greater Accra. And that's enjoyed about 50% or more response rate or reporting rate. The other region, which I'm sure the reason I also know far-fetched, is Ashanti, which certainly is a magnet on its own. So that is it. So the difference in terms of socio-cultural and opportunities, between the deprived and the urban areas is the reason. And on top of it too is about compensation and working conditions. What we've also delved into and come to notice is that if you are a medical personnel, and you are in the urban area, for instance, you have opportunities to do some extra work. We call it locum. I'm sure you've heard or know about it. Okay, yes. And if I go to the deprived area, I may not get the same opportunity, yet we are paid the same. And you may even be working more than somebody who may be working in this urban area. So you are placed at a disadvantage. Remember also that social amenities, roads are relatively poorer. You may not get cable or satellite television sometimes. Accommodation may be a challenge. And most doctors are also middle class, as you call it. So they want the best for their case. They want the best schools. You may not have such opportunities in the rural areas. I know doctors who hold 2 homes, one in the urban center, one in the deprived area, just so the family will be in Accra or Kumasi or those areas, and then they can go to these good schools. So they traverse, between these places on a regular basis at the peril of their lives.
Okay.
At no extra compensation. In fact, they are losing out in all ways. So we know the reasons, and we, as Ghana Medical Association, in the past have called for some reforms, and I think that we need to take the bull by the horn and decide that as a nation, this is what we want. We want to put, our monies where the need is, and many times we say, "Oh, okay, what about the money that we use to train you?" Yes, the government or the nation uses resources to train these doctors and other health professionals, but we also know that health is one of the priorities of this nation. So rather than get stooped into that discussion, what can we then do as a nation, as a collective, to ensure that the people whose taxes are being used to pay us in these deprived areas also get served? And I think that as a nation we have failed up to this point.
We'll get into we'll get into the solutions, but before we do, let's begin to understand the problems in detail. And in order to understand the problems that you've talked about in detail, let's do it this way. So first of all, if you know, tell us how much are fresh doctors paid? So once you posted, on the average, how much are you paid?
There are various ranks, and it will be difficult for me on top of my head to know, but I think it's in the region, at least the lower grades, 4,000, 5,000, give or take. I won't be very accurate, so you can imagine that this is certainly woefully inadequate considering the current economic circumstances of, utilities that you have to take care of, your rent, family, school fees, family demands, and everything else.
So let's look at it this way. You talked about the fact that give and take 5,000. Let's take 5,000 for purposes of analysis, and let's say that the average age of a fresh medical doctor is around 24, 25.
Yeah, you are not far from correct.
Great. Now, that is the period that you're just starting life. And so then the conversation about your family, not really in the picture for now because you're just starting life, right?
Sure. Yep.
Good. Now, these areas that you're moving to, in most of the instances, you'll be giving accommodation, right?
Winston, you see, even the first presumption may not entirely be accurate because some, doctors get married while they're in school. I'm aware of many instances. Some give birth in school, and at the time they are medical officers. But that will also mean that they've practiced for at least 2 years post school, because they would have done 2 years of housemanship. So they are not that young, And if they did other courses, maybe the 4-year courses, they probably would have, be at management level now. So those presumptions may not hold as you put it.
Yeah, but the question I was asking, the fact that when you're posted to these areas, are you giving accommodation or you're expected to get your own accommodation?
Oh, if you are lucky, you would be given an accommodation, and some districts have accommodation for doctors earmarked. I must be frank with that, but it is not everywhere. Sometimes accommodation issues have delayed doctors and other health professionals assuming duty, even if they have accepted to be posted there, and it becomes a back and forth until one is secured. Many times you have to look for your own accommodation, and then you may be reimbursed or it's at your own cost.
Okay, so let's look at the average. On the average, what percentage of doctors get accommodation provided for them by the district or probably by extension the hospital?
This because this is a very discerning platform, I don't want to commit myself to numbers, but I can assure you that majority do not have accommodation ready at the time of moving to their place. They have to get their own accommodation.
Great. Now, you talked about the fact that, you've talked about the conditions of service and even the conditions in the hospital. But let me also understand something, because as doctors, your training, the reason you are doctors is to save lives, right?
Yes.
And
Famous.
wherever there are lives, the expectation is that you should be there to save those lives, right?
You are right.
Okay. Now that the expectation is that wherever there are lives, you should be there to save those lives. What then, beyond all the challenges you've talked about? So you've talked about amenities, conditions of service, the other things, maybe the road networks may be poorer. Today, internet service largely around the country, because I'm looking at, these areas. I see even Western region has 38% of the people allocated going there. Now, in the current dispensation, where internet connectivity is largely all over the country, where many of the roads are motorable, where you probably could find a building closer to where the hospital is.
Are we in the same country? I travel around this country, and you say that most roads are motorable and internet connectivity is good everywhere. Absolutely not.
No, I didn't say internet connectivity is good everywhere. Largely within the country. I travel around to Prof, and wherever I travel around, I'm able to use the internet. Yes, some areas.
But between 2G and 5G, which one would you want?
Okay. Tell me, which one would you want between 2G and 5G?
Of course, the answer is obvious. So if I'm posted to a deprived area over 2G, I could say, and sana, menya reception. Now, the nuclear who say, I can't download any information on the net. I'll be frustrated, and it will build up. And eventually I will say, can I move out? So I agree with you, that doctors are expected to be altruistic. And in fact, it's in a Hippocratic oath. And the issues of our training, I'm a teacher, so I know what I'm saying, is to save lives, through in a professional way. But Winston, let me just flip the question. If multimedia decides that they are taking you to, forgive me, nobody should come after me, say Bunkrugu, for instance, today as a posting for multimedia, I'm sure here they probably will take care of accommodation and all, but they will have to make sure that where they are taking you, you are comfortable, So we are not asking for anything extra, but the fact that, you need the services as a collective, because all doctors and health workers are potential patients. You should provide and make it possible for them to accept and stay, because there is nothing after life. You understand? So it's not a competition. It is not being treated specially. It is for us to say that as a nation, that health is important. We need to get these people where it is needed, so that the poor person in the deprived area is also benefit from the taxpayers' resources. So, can I appeal to Ghanaians as a leader or as a minister also and say, yes, we are paying you 100 cedis in Accra, but if you move to say, this place, we want to top it up a little more so that you are more comfortable, provide amenities for you, and then you're able to serve the people of this country. That is what we're asking for.
Prof,
Yes.
Let me ask you this. You've talked about the Hippocratic Oath, you talked about the altruistic nature of your profession.
Yes.
And one thing is very clear, that any doctor who is posted to a remote area is really required to sacrifice. Now, my question is, we see examples of doctors coming from the United States, the UK, Germany, developed countries, to come and live and work in third world countries like ours for months, years on end, to treat people, sometimes even for free. They are willing to sacrifice for us, even though we are not, they are kinsmen. So is it fair to say that when 32 doctors are posted to one region and none of them turn up, then it is a clear indication that our doctors are not willing to sacrifice?
So if we look at the global picture, that answer of the response in accepting postings, that answer may not entirely hold, because some people or some doctors accepted posting. Now, if you drill down, you find this very stark picture that you are painting with some areas where 0 persons accepted, and the reasons are some of what we've already spoken about. So I think we should concentrate on the reasons. Now, I agree with you that we're supposed to save lives, and we've been doing so, and we continue to do so, and we are happy doing that. Okay, and I will not be here and say that doctors should not sacrifice. And as a leader and as a collective doctors collective union for all doctors in this country, we have been preaching that. In fact, we have been at the forefront of making sure that's happening. Let me give you an example. The Volta division, the regions, we call it divisions, a couple of years ago, decided to take matters into its own hands, not in a bad way, but in a positive way, by giving doctors who accepted postings their land and other incentives. And they needed only 5 doctors, as much as 20 doctors responded to that call. So it is not something out of the ordinary that we are speaking about, and we are not saying treat anybody specially. We will continue to appeal to the conscience and the good deeds of these doctors and other health professionals. But we are saying that facilitate that process and enhance the acceptance so that all of us, it doesn't matter where you find yourself, benefit from the services of these health professionals.
Prof, the concern for me is that some of the issues that you've raised, which are all very valid, by the way, family having to move to another part of the country where, there are no appropriate schools for their children, doctors not having the opportunity to do locum and other things to augment their salaries. All these things are valid concerns.
Sure.
But the thing that concerns me is that these problems, the solution is not round the corner.
No.
Right? It's not round the corner. Bringing good schools to Bumpurugu is not something that will happen in weeks or months. So in the interim, the only way to ensure that the people of a place like Bumpurugu also get access to healthcare is through the sacrifice of doctors who the state has trained. Without that sacrifice, we are in trouble. So, Doc, it's a chicken or egg situation. Prof, sorry, it's a chicken or egg situation. A sacrifice must come before the solutions come. Don't you agree?
Well, I think you put it right. So the chicken and egg situation goes both ways. It could be an incentive leading to the sacrifice, or sacrifice leading to acceptance, or both at the same time. And I will go for the latter, and I will say that both at the same time. And that's what we are doing. We are calling our members to continue to sacrifice and accept postings, but we are saying that facilitate their acceptance. And we cannot run away from that. I think we can play the ostrich. Look, if you go to the US, Canada, I've been in sessions, meetings at the very highest level. Even in continental Europe, go to China. If you accept posting to a much more deprived area, there is an incentive for you, because you don't expect the doctor to go and live in the cold of Alaska, and I will be in Miami swimming, or Florida, enjoying the beaches, and you say that all of us should be paid the same. It doesn't work that way. So it's been done. It's doable. There's a document at the Ministry of Health as we speak called the Deprived Area Incentive Document that the Ghana Medical Association was part in developing. It's gathering that. Because we recognize that must be done, despite the moral assuasions, which I agree with you. So, and the picture is clear from what we've seen. It's the clusters around Greater Accra, Central and Eastern, and then Ashanti. That's it. The rest, the acceptance rate was below 50%. So the solutions are not far-fetched. So as a leader, if I were the one to take the decisions, I would be bold and say that I will have a dialogue with Ghanaians to tell them that this is our situation. We need our folks in the deprived areas to be taken care of. It's not just doctors, the nurses and all are all inclusive. Can we do something extra for them to facilitate their acceptance and their stay, so that you and I, my grandmother who is in a village somewhere, can be taken care of when he makes it? So I think the conversation must be both the carrots and then the stick.
Okay.
Or the incentive plus, moral assuasion.
So the takeaway is that you're prepared to go, irrespective of the conditions, if at least you are incentivized by way of improved salary, you will go.
It is not just salary, Winston. Maybe if you are concluding, let me add this, that opportunities for postgraduate training, it's also limited in these areas. And as a matter of fact, you have to stay largely in the urban areas to become a specialist. So that's one of the pull factors. And I'm glad that, the Ghana College of Physicians and Surgeons, have seen it, and they try to decentralize training for postgraduates to become specialists. And secondly, they've also introduced modular programs where you can stay in your district and periodically, maybe a month, you come to the training center, do some training and go back while still offering service, to where you come from. So those are some of the things. And in my lead up to my election, I spoke also about why not give people, incentive to set up even health centers in these areas, because it's not just a human manpower not just manpower deficit. It's also about facility deficit. So, for instance, these are the 111. Can we partner the private sector? And one of the things we spoke about during our just ended, annual general conference. How do we leverage private capital, private resources, all the resources that we need to improve health delivery in these deprived areas? And if I set up there, can I enjoy some tax incentives, for instance? And it's one of the things that I'll be raising with the minister, with my team, when we are getting call on him somewhere next week, that we stand ready, to partner anybody to make sure that this unfortunate situation is reversed in the shortest possible time.
Professor York, thank you very, very much for joining us this morning. We're grateful to you.
Thank you, Winston.